Get your curiosity right.
Mad Bricks webcast,
Where the human spirit flies. Mad Bricks webcast. Where the human spirit flies.
Hey, welcome to the Mad Bricks webcast. This is Raman Raju. I'm the host. Yes, I'm the host. Thank you for joining. And last 2 days is a challenging. I started cooking something. I don't cook much. Cut my finger. So goodbye to cooking. But anyway, let me bring my co-host, Susan Davis. Dr. Susan Davis is a doctor of nursing practice from Ocala. She's joining from Fort Myers, Florida. Is going to join up. We have a very interesting guest, my old buddy. I met him in Washington, D.C. Let me bring up first Dr. Susan Davis, beautiful, bold, brainy. Welcome.
Good evening. So inquiring minds want to know, what were you cooking, Ramana? What were you trying to cook?
Andhra chicken curry. Dr. Reddy knows how we he like Andhra chicken.
Andhra chicken curry.
Surprised, about Dr. We are from Dr. Prasanth Reddy is the coming guest. He is actually came from my area of the town.
So I might still have a chance. I don't like giving up so easily on my curry. Thank you very much.
I know. So how is what are you doing nowadays after long travel? You did something, and what's going on with you?
Oh my gosh, what's not going on with me? I mean, once you become the American Heart Association's Woman of Impact nominee, I mean, things change, Ramana.
That is a big thing.
It's very exciting. Our campaign launches next week, and even cooler is that the American Heart here in Florida is working with me because I have a really specific ask. It's kind of funny. I've never fundraised before. And so I feel funny kind of sort of asking for money, but not when it's for my cause. So they're allowing me to do like prescriptive asking, meaning if people donate, they're going to be able to decide what they want to put their money toward. So really cool is there's a giant need, not only in our state in Florida, but across our country, because last year, 2025, there was legislation passed, and I'm going to make this number up because I don't remember exactly, but somewhere around 30 of our states passed a CERP, a cardiac emergency response plan. So it's mandatory for our schools, where our children are on the daily, to have not only the equipment they need, but everyone around them have the training and a plan. So I'm going to use that as my platform here in Florida to set precedent and set a standard across our nation for this particular campaign, the Go Women. I'm sorry, the Go
Red.
Go Red for Women of Impact, to be able to prescriptively, take care of their particular state's schools. So that's what I'm going to do. So I'm totally psyched because there's different levels of ways you can contribute, but you can make sure that our children, put your money where your mouth is. I say, put your money where our children are. Let's make sure that they're safe in school. And so very exciting, more soon, but that starts next week.
Okay, without further delay, let me introduce you my upcoming guest, Dr. Prasanth Reddy. He is from my neck of my woods and back home, but he is also, I met him in Washington, D.C. Actually, I don't know, he's coming from a Kansas City joining. He's a Tundra. We met during the January month. Oh my God, it's cold up there in Washington, D.C. I met him during that time, So let me bring a Dr. Prasanth Reddy, oncologist. He's a lieutenant colonel in the Air Force. He has all the credentials, and he ran for U.S. Congress, for Republican Party, actually. So you almost won. Okay, welcome, Dr. Reddy. Dr. Reddy, welcome. How are you?
I am doing fantastic. A little chilly. The whole country is
you remember
cool
we met in we met in I think she's playing the Navia is. Yeah, yeah, we met in cold weather during the time, and that remember it is a challenging. But you ran for one of the things I loved about you is you took a bold step, and you really who introduced you is a Palomito, is a Dr. Palomito introduced us, and the Dr. Chetipal is. That's the first time I saw you there. I was so impressed. After that, you've been coming like a. Susan, he is a frequent guest on my show now. He's like a third time or so.
Oh,
Dr.
good to
Reddy,
know. Good to know.
Dr. Reddy,
Yeah,
yeah.
no, I got to say, Ramana, I think what really attracted me to your podcast, and now with Susan on as well, is the core principle is how do we advance humanity, and how do we do it together, and that's a fight worth having, right? So that's something that we can all get excited about.
Very
Absolutely.
exciting. We love that part.
Dr. Reddy, one of the things is that let us talk about a little bit about you ran for Congress, and you're almost won, but the policies. Let us talk about the healthcare policies that you are good at it. You articulated very good in the debate. So I wanted to ask you that particularly let us talk about here a hematologist oncologist. So let us talk about the cancer policies in the federal FDA. We have a common friend. I mean, he's acquaintance to me, at least Dr. FDA chairman Dr. Maki Makary. He wrote an excellent book, Blind Spots. But what is the general policy? He's a great guy, by the way. But what is the general policy of cancer from the federal point of view? How do they prevention or treatment or the whole policy? What do you think of that policy? The structural policies.
Well, for sure, Ramana, maybe I start with this is like every time we look at a problem, we have to understand the scope of the problem. And so for me, I knew when I was very little that I wanted to become a doctor, and honestly, a cancer doctor. And part of the reason is that cancer, and Susan just mentioned earlier the importance of heart disease. Cancer's right there, right? So when we look at the United States and even globally, actually, cancer is the second leading cause of death in the United States, approximately 600,000 deaths annually. And just so folks remember, it's literally 1 in 2 people will be afflicted with cancer over their lifetime. So that means when we go into a room, a conference room, to our workplace, sadly, even home, and we look around the room, 1 in 2 people in that room will be afflicted with cancer. And so that's the first thing. Separate from that, I would say is during the course of my own lifetime, because I've been involved in research. As you know, I have an MPH, and I've been involved in cancer research. I still take care of patients 1 week a month in underserved areas. I drive 4 hours each way to go see a cancer patients in a small rural clinic. And the truth is early detection shifts survival literally across all cancers from about 20% when you get cancers at later stage disease to over 90%. So, in fact, I'm the chief medical officer of a cancer screening company now based out of Boston called Mercy Bioanalytics. And so we're focused in trying to do early detection and also improving cancer screening across a number of cancer subtypes. But the truth is innovation is amazing. And over the course of my lifetime, we've done amazing things for diagnosis, prognosis, therapy selection. What are the potential treatments we can offer to our patients? And the list goes on and on. But the truth is we got to take those innovations and get them in the hands of patients. And this is where the government can be particularly helpful, right? So the private sector can't solve this on their own. And by the way, the government can't solve this on their own. And it really takes that private-public partnership, which I think, Marty and certainly other leaders, that I know in the government, I think they're committed to ensuring that we continue that private-public partnership and figuring out how we can help patients. So there's an absolute role for the FDA and the government. We need to support cancer research, and we need to be able to get implementation fixed. So all these great innovations get to the hands of patients.
That's everything. It's the implementation. I'm sorry, Romana, but this is a really big point for me in my work as well, Dr. Reddy. Implementation is everything. We can all talk the talk, but if you can't walk the walk, it's not going to get where we need it to get. So in my work, the same as yours, we can get everything in the world passed, but if it's an unfunded mandate, then what the heck? It dies right there, which I'm going to call baloney on, like complete baloney. So I'm in the same shoes as you are for the, cardiovascular disease, oncology stuff, cancer. We need to be able to get all of the delicious research and this magnificent innovation to the streets, to the people. So thank you for that. I think the public, people need to understand that partnership. It's huge. We got to bring in money. We got the rules, the laws, the rules and the regs and all the line items and the bureaucracy, and then we need to fund it to get it to where it needs to get. So sorry.
Ask you, because Susan, one second important thing I wanted to ask you about the prevention part of it. I'm a physicist first. We have a scientific American and an article about it. It says that the prevention actually is a myth. It says that most of the time it's the late stages of biology already taken place by the time you see the patients. That's what one of the claims is. Is it prevention is really a myth, or is it really you can prevent the cancers in general?
Well, so part of my job as a cancer physician, and honestly, even in industry as a chief medical officer, is to translate incredibly complicated concepts. Here, in this case, not physics. Physics is more complicated than medicine in many ways, but medical concepts so people can understand, right? Part of this is, I joke, I've been in the Air Force for over 20 years. As you said, I'm a light colonel. I always tell my patients, look, we're in an airplane together, but you control the joystick. You're the pilot. I'm your navigator, right? Ultimately, you with the joystick can decide where we're going. But my job is to give us options, and then there's always multiple paths, right? I can look at my path. Do I get on a clinical trial? Is it I go on standard of care? I've also completed in a month an integrative medicine fellowship. I know the molecular biology of cancer extremely well, but using food as a medicine, using exercise as a medicine, even spirituality as a medicine. These are elements of the whole person. And if we don't understand the whole person, we'll fail in taking care of that individual person to achieve the best outcome. And so it's really this combination, but ultimately it is not a myth, right? So there's a great article, by doctors Hanahan and Weinberg that looked at the pathogenesis of cancer. And we don't have enough time today to talk about the pathogenesis of every cancer, but suffice to say, there's very specific mechanisms. And at the end of the day, cancer is simply uncontrolled cell growth. And how those cells get to that phase of uncontrolled cell growth, we can categorize whether it's angiogenesis or loss of or metastatic potential or loss of inhibition for apoptosis and cellular death when cells develop mutations and so on and so forth. But there's specific categories that can lead to the development of cancer. And absolutely, it's incorrect to say that we can't prevent cancer. The challenge is can we prevent every single cancer in every single patient? The answer is, of course, that's our ideal, and maybe we miss some folks. But there's absolutely no doubt that we can prevent cancer, and there's a number of ways that we can do that, right? And first and foremost, to be honest, is honestly lifestyle interventions, right? Things about what are we putting in our diet? How are we eating? Are we exercising? Those things are very, very important for cancer prevention. So we have lots of tools in our toolbox. And I think this is, again, when we talk about government and private partnership, we're really looking at how do we look at these public health interventions and convince folks that a healthy diet and exercise and having good mental health, having some kind of spiritual connection, all of these elements of a person can lead to better health.
1 second, Susan. Let me.
I'm holding back. Go ahead, Romana.
I just a question for you. The policy translation that prevention in all aspects of lifestyle medicine that you're saying, spirituality and the mental and the food as a medicine. How much the policy is helping if you're putting a Kentucky Fried Chicken everywhere in the 10 places same time, in Silicon Valley we had one Kentucky Fried Chicken and then it's closed. So but if you have 10 of them in a neighborhood, it is a problematic. I mean, I'm not saying I'm not going against any Kentucky Fried Chicken in general. I don't want to say anything about corporations in general. Uh, the problem is if you are not availability there, and these are all, it has to be supported by this infrastructure, by the government policies, right? So lifestyle medicine itself is must be taken over by the government itself, that push that federal government has to push that policy itself in the forward. Do you agree?
I totally agree, right? I mean, let's talk specifically about, risk factors that are lifestyle risk factors. Tobacco. Well, it took us decades to say, smoking cigarettes was bad. Can we do better? And yes, it's sad that for me that when we see things like that, it takes decades for us to understand that, this is where policy impacts things, right? So even today, 30% of all cancer deaths, and it's not just lung cancer, by the way, it's many subtypes of other cancers that can be, have an increased risk of prevalence if you're smoking. 30% of cancer deaths are still attributable to tobacco, right? If you look at inactivity, you look at diet, there you're talking about maybe 15%, half that, right? So obesity, metabolic syndrome, inflammatory states, alcohol, right? Think about, I mean, it's pretty everywhere, right? And it's 5% of cancer deaths are related to alcohol. Infections, right? We talk about, HPV vaccine programs, right? Hepatitis B, even H. pylori, to be honest, right? So for gastric cancer and things like that, 13% globally, right? And then inherited cancer syndromes, which are a little bit trickier, right? There's not something we can directly remove as far as genetic risk, but 10 to 20%. And in those populations, there may be ways that we can reduce risk through surveillance, and sometimes even surgical interventions, prophylactic surgical interventions. For example, people that have BRCA mutations that are much higher risk of, say, breast and ovarian cancer, you may do risk-reducing surgeries. So the first thing, though, is we have to understand the biology. And that comes from this public-private partnership. And we're in an awesome era where, for me, it's the legs of the stool. And in medicine, historically, and this will never fully change because you always want to listen to the patient, the history is incredibly important in making a diagnosis. The exam is important, but in today's world, our technology, particularly with imaging and laboratory, is providing much more objective, precise, accurate, actionable information. And then the last piece is, okay, fine, I'm describing all these cool things, and that's awesome. Well, what tools do I have in my toolbox? And just in cancer medicine alone, in my lifetime, we've gone from standard conventional chemotherapy, which I sometimes equate to, like conventional bombs, a lot of collateral damage, not very, precise, to now we have targeted therapies, which are like smart bombs, where we go and say, the bad guy is there. And now I can deploy, a smart bomb, like say targeted therapy, and goes just there, right? Only to the cells that have that particular mutation are affected. By the way, it doesn't end there. We have immunotherapies, right? And some of these immunotherapies are incredibly effective in unlocking the immune system to do what it's supposed to do, which, by the way, is another one of those pathogenesis mechanisms of how cancer can develop is, a dysfunctional immune system or immune surveillance, and then it doesn't even end there. So again, I'm a military guy, so I'm just going to use these analogies. Analogies and stories work, right? So we even have things like, let's say SEAL Team 6, who are trained in Coronado Island, and they're specialists. Well, guess what? In today's world, we can literally take white blood cells out of a person, train them, and then put those same white blood cells back into the same person, and now they're like SEAL Team 6. And they
Get out of here. Get out of here. That's awesome. What is that called?
Yeah, it's like CAR T therapy. Right? It's like CAR T therapy, right? And it's not just CAR T
Oh,
therapy.
I didn't know that. I mean,
Yeah.
I've heard
So
of
and
CAR therapy, but I didn't know that's what it meant.
yeah, and we have more than that, right? I mean, so we have vaccination programs. Vaccines can be important. Like, we talked about HPV and the importance for certain kinds of head and neck cancers and other cancers as well, cervical cancer and so on and so forth. So there's a lot of tools in our toolbox, and maybe the last lens, and this is so exciting to me because when I was growing up, I'd have cancer patients and they would still be functional, but I ran out of tools. In today's world, there is no excuse to not look under every stone because we can do that early in that cancer patient's journey and offer so many tools to say, hey, is a clinical trial the right thing for you? Or if we have great first-line therapy, is that the right thing for you? Or if we have sucky, that's a scientific term, by the way, therapy, maybe we need to think outside of the box. But this is that shared decision-making at the individual level where, of course, population health defines guidelines and what we should do, but population data breaks down at the N of 1. So we need that to have general guidelines, but then we need the flexibility to say what's right for Sue or what's right for Ramana. Well, not Ramana, right? Hopefully you never have to deal with cancer, right? But the idea is what's right for that person, and it's that shared decision making. And we really are in an awesome time,
Awesome time. Awesome time. So it's all about information, and how early can we get it and how far upstream can we get? So no one can, I'm sorry, but I'm pretty sure people know the difference between an apple and a Big Mac. So I know that we need to be careful with the minerals and micro minerals we're putting in our mouths. I don't think people realize if you look, Dr. Reddy, at a tree in your backyard, think of what it's taking for it to grow. The minerals from the soil, water, and sun, and that's it. So we are virtually very similar. People think we're just so different, but we're really not. It takes the micro and the macro minerals, some water and some sun for us to grow so wonderfully. So my question to you is, often when disease, not just cancer, shows itself, it's kind of late in the game. So early detection is everything. And I know you are working right now in this cutting edge early detection stuff. I think specifically in ovarian cancer. And then I keep seeing little secrets about lung cancer, something coming up that you guys are working on, some really cool things. So what's the story on early detection in those areas?
Yeah, so there's all kinds of ways we can look at early detection, right? And I don't want to get too technical because I'm going to bore you guys, but there are signals, that we can look at, and it's not just in the tissue, right? A historical way to make a diagnosis, we used to say, and we still say, tissue is the issue. So to get a cancer diagnosis, we do a biopsy, right? And so that's how we, even today, make a formal diagnosis for the vast majority of cancers. But what's really cool is that cancer is setting out other beacons, signals that allow us to detect when it's present, even in the bloodstream. So we can use imaging, but we can also use other techniques like looking at the blood and say what's being shed into the bloodstream. And so, yes, there's say, I'm just going to pick one. Let's say there's an EGFR protein, which is important for a number of cancers, including lung cancer. Well, if there's a mutation in EGFR, by definition, that's not a normal cell. So if I see that signal, I know something bad's going on. Now, if I see a normal EGFR protein in the blood, that's normal. We all have EGFR. The problem is when there's a mutation, and that mutation can then be one of the many, many, many ways a person can get a cancer, right? And so one of the interesting things, and Sue mentioned this earlier, is information is never a bad thing, right? We have to understand these things. And so, because I bring this up because, we have an opportunity through government to understand, the biology of cancer at a population level. If we did, for example, genetic sequencing on every single cancer patient, that to me is a no-brainer. Now, people will say, what about privacy? Right? Oh my gosh. Well, guess what? Every day we have financial transactions that are very important at the individual level that are also protected. So yes, we need to put in the appropriate safeguards, but we have to be very careful that we don't take advantage of this amazing technology to do what Susan said earlier, which is understand the biology, right? Because once we understand the biology for everybody, because I can also tell you the rates of EGFR are different in Asians than they are in Caucasians, than they are in Black Americans. And so if we just sequence a certain group of folks, we will not understand the biology because we're missing the fact that it varies. The biology of cancer varies between men and women, between potentially age groups, exposures, your race, etc. So this is exactly what that public-private partnership is, and where government steps in is when private doesn't have access or the tools to be able to do these things at a population level.
I have to ask really quickly, Romana, before you hop in. Okay, so you go for your yearly CBC, CMP. These biomarkers are not included, right? It's such a general profile. In today's day and age of precision medicine and longevity medicine, when the heck are we going to bring in these biomarkers earlier, way upstream? I don't want to go to you for these cool tests when I think I might be sick. I don't want to get sick, Dr. Reddy. I want these biomarkers done on my yearly. What say you on this?
It's a perfect thing, right? I'll give you an example on lung cancer. We just spoke about lung cancer and how tobacco is still a very important cancer risk factor. Well, not long ago, just a handful of years ago, the National Screening Lung Trial was completed and said, at least for people that had high risk for lung cancer based on their pack year smoking history, that they should get screening with something called low-dose CT. Now, low-dose CT is covered by the federal government. Yet, maybe, depending on what data set you're looking at, maybe 5 to 15% of patients are actually getting low-dose CT. Why is that? Well, Susan, you just brought up an important point. It's convenience. So when I think about, how are we going to get implementation done? For me, it's literally 4 things. Does the test do what it's supposed to do? Can we trust it? Hopefully no more Theranoses out in the world, right? Mm-hmm. Number 2, is it easy? Meaning, can we integrate it into a clinical workflow where it's not like some, only this White Castle that's not realistic for the vast majority of the people in the country to get access to because they don't have cancer navigators and other things. Is it easy? Tying back to your annual physical, right? If I'm already drawing a blood test, why not throw in a Mercy Bioanalytics test? Once we get fully validated, right? We got to still do the science to prove it's a good test and do the things that we need to do. But once we get to that phase, why not just throw that in to the annual CBC and CMP and lipid profile? Now, what you've done is that implementation, that second piece of it, you've made it easy where now, even though we have a low-dose CT test, which I do think people should get if you fall into that high-risk category, for those folks that for whatever reason aren't able to do it, now we have a blood test that can help figure out whether they're at increased risk for lung cancer. Third and fourth things are also easy. Now, the third thing is cost, which the federal government can also help with, right? Which is, for example, for women's health, HRSA can be important for rural health, women's health, preventative services. And we have to look at mechanisms to go through how are we going to get these things covered. And by the way, an ounce of prevention. I'm gonna, sadly, I lost my mom in 2024. It was a rough year. I lost my election run too, but it is what it is. But an ounce of prevention is worth a pound of cure. And so an ounce of prevention is worth a pound of cure. So when we think about expense, and we think about therapeutic expense, and we have all these awesome tools, even better than all these awesome tools after you're sick, as Susan and Ramana, you both highlighted, is to just prevent it or at least stage shift it so that instead of, a 20% survival rate, we're talking about a 90% survival rate if we can at least get patients detected earlier, right? So all this makes sense. And of course, there's a medical legal risk, and that's also policy. So as long as doctors are not doing crazy things, and I'll say this, I can just I can say this because I am a doctor, right? We have to hold ourselves up to a higher standard. And so I never get worried about lawsuits. And the reason why I don't is if there's something complicated and I don't know the answer, I'm the first person to tell my patient. I did this like a month ago. And I said, you need a second opinion because we're in a difficult situation. I'm struggling to figure out, it's not plan A. What are we doing today? I always have a plan B and a plan C for my patients. And if I don't have a plan B or plan C for my patients, then I say, I'm struggling with that. And me as an advocate for you, we need to figure out, is there a better plan B or plan C? And so it's about transparency. It's about trust. And it's about, that is how medicine's supposed to work. And, that's good medicine. So.
That's good medicine. That's another mic drop, Dr. Ray. That's exactly right. Come on. We all get biomarkers, friends.
That Dr. Reddy, the biomarkers are new. I'm in Silicon Valley, liquid biopsy and all those free DNA markers are coming up. But, traditional things, I used to run a diagnostic center, mammography, for a woman. And it's a very difficult to get. It's 3 months. Sometimes they wait for 6 months. So that is still this infrastructure problem, the MRI breast scan or something like that for MRI, breast screening test. So there is a big investment involved, but particularly in rural areas, MRI is not everywhere there, or CT scan is not, and then radioisotopes, if you do a contrast, it's all challenges are there in the infrastructure. What do you think? It is some places bad here. Think about in the world like India, some rural areas, it's worse, right? So how do you solve this problem of infrastructure, problem of these particular screenings?
So we talked about the tripod of cancer medicine, right? Which is, the first thing that I would say is that, okay, how are these diagnostics like working, right? Like imaging or laboratory, this, like how do we get objective information that we can act on? That's one piece. The second piece is, okay, I got information, but can I do anything? Well, we just went through like an awesome toolbox, right? We have all kinds of things. And it's not even the full toolbox. We didn't have time to talk about all the other tools that are in that toolbox. But therapeutically, we can do a lot of things, right? Whether that's surgery, whether that's radiation oncology, so radiation, very new, methodologies there as well, or therapeutics, like medical oncologists like me that have those tools, right? And then the last piece is data. Not just AI, but data. And we talked about gathering this data. And then we talked about how do we apply the data science and extracting out those right insights to then help population health. And part of this tech part of the stool is also part of that innovation. How do we deliver care? So telemedicine, EMR nudges, right? We're all human, and there's a lot every day. There's like so much new information as a cancer doctor, and certainly as a primary care doctor or any kind of doctor. There's so much information. It's hard for us as human beings to always know everything, every single minute. And so all of these things, we can take technology and apply it to make the delivery of healthcare better, whether we do it through telemedicine, whether we do it through effective clinical trial design, whether we do it through, say EMR, being a great place to apply AI or other techniques to then say, hey, don't forget, this patient has this, this, and this. You really should be thinking about this. I don't view this as a failure of doctors. I view this as a way that, again, it's a partnership of using these tools to help doctors do the best for their patients.
Yeah.
We can do this.
Increase the surface area massively. Surface area is the answer. Hierarchy is not generally the answer. Surface area increasing always works.
So you brought up India. And so, I'll give you an example. In India, it's literally almost every single person has a cell phone. Now, that may not sound like a big deal, but why can't we use technology, whether it's an iPad or a phone, to enable patients to, Susan, I'll use your terminology, that surface area. Another way for that is say engagement. So the first step for us to fix in the healthcare system is to get more people engaged in the healthcare system. But the only way we'll be able to know when they're sick is not when it's too late and they're already sick, right? How do we can prevent things from getting to that that eventual diagnosis if we're interacting and preventing the sickness from taking hold.
So I think something you said just struck with me. You said if we can get them to engage with the healthcare system. I'm going to take that back just one word and say if we could just get them engaged with their health.
Yes.
Let's just get them to engage with their health. And then the next step would be the system that might be helping them engage with their health, rather than because if people are afraid of the system, and let's start with their health. I think that would be a really good.
I dispute
agree with
both
you,
of you about that. I tell you why. I dispute that. That is the last time Dr. Reddy was talking about individual responsibility, he says. But I think, in my view, there's a systemic problem. Individual responsibilities, when you have a large number of people in that particular population is overweight or some other high risk cancer or anything, high risk infectious diseases, there's a systemic problem. We need to recognize that rather than individual. We are pushing individual. That's, of course, I understand that part. But this is a high time for the United States, particularly, the healthcare system of its broken system. It is a institutional, it's a systemic problem. I think that. Do you agree with that? There is a systemic problem there, or just is individual problem, you think?
No, it's not black or white, and it's not you're either with me or you're against me. It's
Yeah.
the truth is often in the middle, and we need both. I this is weird. I'll just say it. I'm a lifelong learner. I'm getting like a second business degree right now. I already told you about integrative medicine. I'm also working on a master's in theological studies, and I do it because
So cool, Dr. Reddy. It's a whole other show. We're gonna have to come back and just talk about that.
Yeah.
But the truth is that we all can get better. Don't dwell on the past. Don't dwell on it's not a failure. But if we come in antagonistically saying you failed, you didn't do this, you didn't do that, then you're going to lose people. So the idea is don't make them feel bad about what they should have or could have or whatever did. We need to encourage them to take those steps to make their lives better. And it's just a shuttle tone shift, right? But it's an important one. And we can do this, but it's both, Ramana. It's both. It's not just the system's going to fix everything for us.
One is education. Education is one part, and the infrastructure is the other part, right? Let me ask you. Then I'll hand over to Susan. The people think cancer is a death sentence. A lot of times, the problem is a disease itself. Is a financial aspect. It's like people think I'm going to be broke. My friend said that one of my friends got infected. Unfortunately, he got stuck with the cancer. And then he said that for $30,000 a month experimental drug cost for him. And he said that, I'm glad I'm in that particular plan. Otherwise, I would have been screwed, completely filed bankruptcy. That system is a problematic a little bit, that equity and access is not that equal there, right?
Yeah. So the most expensive part of the healthcare system is end of life care and therapeutic cost. And we just spoke earlier today about the importance of shifting, a disease. I'm just going to pick cancer because that's what I do, right? Where we said if you have late stage disease, we're lucky to get survival rates in 20%. And if we can move that earlier, right, instead of worrying about systemic therapy in late stage disease, maybe we just cut it out or radiate it. Or we cut it out and radiate it and only have a temporary period where you need systemic drugs. That's called adjuvant therapy. And so the idea here is that's not, unlimited cost forever till, unfortunately, maybe you pass away. And so when we think about the health economics, right, and I've done a lot of stuff in the payer world too, the way that we're going to shift that cost is to go to earlier stages of disease where it's still curative. Right. And one step even better, right? We talked about prevention. We can prevent cancer as well. So that's awesome. Now, if we prevent cancer, that's easy. Where's the cost? They're not sick. And if we took the next step, not, metastatic, at least with what we know as human beings, say curable. And instead we say, hey, we've moved it to a curable state. We've reduced cost. So those are things that we can do today. And it's one of the reasons why I'm I've moved, in the diagnostic space into therapy selection, into looking at, hey, can we, stage shift or get cancer patients into where they can be cured, like early detection, and eventually all out, full on prevention. You don't even have cancer.
So education, 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 education. The earlier people are, if they're not aware that a Big Mac is a Big Mac and an apple is an apple, and I'm oversimplifying and being a little bit of a jerk, but I think we're really innately born with the knowledge of what's good for us versus what is not, regardless of the cost. And I've had this discussion with multiple humans on this planet of anywhere and everything. But the bottom line is, Dr. Reddy, Romana, just made the point of the century in my mind, right? So it's very expensive when you're late stage, because that's, what can we do other than treatment, and everything we have, throw the kitchen sink. We're going to do the best we can. That's going to be expensive. And I'll say that we're talking about oncology here, we're talking about cancer, but it's every disease. It's the same thing. So to Dr. Reddy's point, the coming together as a nation, as a world, and teaching people through education and awareness, because somehow they're not hearing us, like Apple, Big Mac, but choosing good, what you put in your mouth and what you put in your mind, and how you move your body can keep you from those costs. It really can. So how can we come together to help people learn the beauties and the deliciousness of a healthy life versus doesn't it go back to the saying that a man/woman with their health has a million wishes and the one without their health has only one?
So there's something, again, I don't want to get too spiritual here, but there's something called free will and there's something called agency. And agency means that I don't feel like I can't do anything. Whether it's human beings or dogs, the original experiments were done in dogs, right? Dogs were exposed to these inescapable electric shocks. And then they were placed in a situation where that inescapable part wasn't there. They could actually escape. Like, it was possible to escape. But many of those dogs didn't even try to escape, because they thought, they had learned that no matter what they did, it was futile and they had no hope. And that's called learned helplessness. And that is a very, very bad thing, certainly for dogs, but certainly even more importantly for human beings. Absolutely. And so this idea here is that we have to get to a place where people don't have that sense of learned helplessness when they do have agency. And that is not, in my opinion, purely legislative. That is helping each other, right? And so that is helping each other.
I'm in on that boat, whatever that is, whoever's doing it, however you want to do it, I'm in. So I don't, it's brilliantly put, and I'm sorry it's so difficult to understand by the masses, but that's where I'd like to work, because I know inherently we all know the answer between good, bad, right, and wrong. I know.
Susan teaches CPR for people. So the same thing, you need to teach them that if you don't, that I went to Selma. I used to place doctors in small rural underserved areas, like Kansas and all those places. Then I went to Selma, Alabama. That's, everybody is overweight there, and I met the doctor there. And then one of the chief medical officers, he said that we don't have a nutritionist for the last 10 years in the hospital. So think about that. Access to information is not that cheap. Actually, information is an expensive system. It's not that freely available. Or as you said, that the dog experiment is the best. Humans is worse. In fact, we are already came with the biases already. So all these things you need to really address at the legislative level, as you said.
I was just going to say, Susan, kindness matters, right? And so, in medicine, part of my job, and I actually in politics, I think it's a little bit of the same thing. When a patient comes in, I have to absorb, because cancer sucks. And we aren't where we need to be. We have a long way to go to get to where we want to go. We made tremendous progress, but we're not done. And so, but part of it's a complex, when you're sick, it's a complex, set of emotions. Sometimes people are angry. They're sad. They're confused. part of my job is not just to prescribe something. Part of my job as a doctor is to absorb that. Right. And now part of the job in politics, which, it's become such a dirty thing, but, it's not Mr. Smith goes to Washington, but it's similar. The idea is part of a job of a politician is absorb the negativity, right? And say, how do I help with coherent policy? And in its purest form, public service, is politics. These elected officials, we're entrusting them to make the right decisions for people. And that is in its purest form, like public service. And it saddens me that, we're so, in a complicated, divided world where I think we all want to get to the same place, a better place. But, when we have differences in opinion, people can come together and say, how do we fix that? And how do we get to that better place? We've lost the forest from the trees. We've lost, where we're similar and say we want to get better. And now we're so divided on how we're going to get there, but we forgot what the ultimate goal is, which is to get better. Right. And so that's a little sad, but guess what? We all have an opportunity at the individual level to make a difference.
Indeed. And the joy is in the journey. And, just conversations like these, just genuine conversations amongst us with people listening. For me, the joy is in the journey, always working for solutions. Everyone Ramana has on this show is doing something magnificent on this planet and wishing the same thing that we're discussing right now. How can we do? To me, it's always implementation. Always implementation. We can talk the talk, but if we can't walk the walk, then what are we doing? It's got to get to the people. So I agree with you, Dr. Reddy, on that.
I wanted to ask you one of the, you mentioned your mother passed away, last year during the elections. You were very emotional during the time I met you. How do you deal with the patients with the cancer? People are terminally sometimes ill. How do you do yourself mentally prepared for these kind of things, or the patients themselves? What they mental state? I'm asking you. You need to be a psychologist probably in this area. What are the tools you have in this to heal yourself and heal the mentally heal the patient?
Well, I'll start with my mom. Right? No son should have to call the passing of their own mom, but I had to, and so hospice. But regardless, even though I knew she was super duper sick, but even there, I shared a couple of things. I said, I love you. I said, thank you for everything. And I said, don't be afraid. And I said, I'll see you again. Right. And so that's it. And so now you can apply the same principles even to cancer medicine. Right. I'll give you two examples. And sadly, I lost both of these patients, but I'll give you one example where it was a lung cancer patient. He was a huge Alabama Crimson Tide football fan. Right. Mm-hmm. He lived Alabama football. And so, again, this has nothing to do with writing a prescription. So I wrote a letter to Nick Saban, who at the time was the coach at the University of Alabama. And I said, Coach Saban, I'm a doc, one of my patients just loves your football team. Is there any way he could come and catch a Alabama football game? Because he's never been down to Tuscaloosa. He's never seen the team live. And so Coach Saban actually wrote me back, and he said, Prasanth, there's like a huge wait list of folks that it may be difficult. And he was very sick at this point, but, he wrote a letter back, and, he sent some kind of swag, right? Like a ball cap and a couple other things. And I got to tell you, him getting those things probably meant more to him than any chemotherapy or anything else that I ever told him. And that was medicine, right? I'll give you another one. This person's still alive, actually. I drive out into the middle of central Kansas, it was like a 4-hour drive. But I go out there, and the patients are so appreciative, and I really appreciate them. And this particular patient was 100 years old. Okay. World War II vet. Okay. And he had been on an island called Bikini Atoll, where they were doing some, nuclear testing, actually. He had cancer. And so when I met him, I was like, holy cow, that is crazy. Like, this is And I basically told him, hey, I would like a picture with you.
Yeah.
And he almost started to cry. But these are the other parts of medicine and the other parts of the things that we can control that are beyond writing a prescription and this is what medicine is. I mean, it also kind of makes me a little bit, I'm going to get myself in trouble, but that's okay. People don't decide when they're going to get sick. And we signed up for this job. And, sometimes when I hear these lifestyle decisions and other things like that, I'm like, wait a second, I get it. There's a work-life balance, all these other things, but we owe it to patients to give it everything we can to make a difference. That's what we made a conscious decision, a choice that we were going to do that. And it's on us to ensure that we're doing that for our patients.
Great story. That's the humanity of the medicine part that I think when we start talking about oncology specifically, it becomes all about the medicines, and it comes about the tests, and it comes about the scans, and it comes about what are you cutting and the humanity stories. They're still humans. They're still our mother and our father and our sister and our brother, and they still are here with us. And so I think those were wonderful human-centered stories, which is what medicine is. It's human-centered.
But the question you didn't answer yet. How do you deal? I mean, you mentioned your mother, but how do you deal with the patients going through mentally? How do you prepare yourself? It's always puzzled me, because I place a lot of the oncologists. I've always saw that, some in hospices every day somebody's dying. How do you handle that kind of situations there?
Look, it's not easy, right? But I mean, it's a simple rule. The day that a person becomes just another number, or the day that you dissociate where you don't care and you just say, hey, that toll, I'm going to avoid it, is the day you should quit saying that you're, a clinical provider. Yeah. I'm not saying it's easy, but that's what we signed up for. That's what the essence of medicine is. And so the short answer is that not easy. There is a tremendous toll, but if you don't have that tremendous toll, I worry about what exactly are you doing? Right? There is an element of, giving that good care that is hard, but it's also the most rewarding part. The most profound things I've learned in my life outside of my parents, right, has come from friends and my patients. And many of these patients, when they have no pretense, they're dying. And some of the most profound lessons I've learned in my life is when they have no reason to say anything else other than the truth, and you hear their strength or their, what they think is important in life, and that grounds you and is saying, wow, that's pretty powerful stuff.
Yeah.
I have to second that, Ramon. I know the question wasn't for me, but Dr. Reddy and Ramona, as a trauma nurse, I've been present for many people leaving this planet. And for me, it's an honor in a way that it's hard to describe, to be somebody that's with somebody at their last moments, not just in traumatic circumstances, but like Dr. Reddy's mother or any of my family members that I have been blessed to be with when they pass. Is it hard? Yeah, the hardest thing there is. But is it also an honor beyond honors to be with somebody when they transition, so that you have that special moment? And it's beyond special to me. So yes, I know the question wasn't for me, but is it hard? It's heavy hard, but it's also a blessing and a joy.
I see the beauty of providing care, people like you and both of you in that sense, in different levels. But I think that still American healthcare system, people like you, makes it much more human and much more compassionate. I think even though there is a lot of skeptics, healthcare system is broken. I hear every day, but I think people like you remind us a good part of the system. In that sense, that I truly admire both of you in that sense. And I'm a physicist. I have to be impersonal. Everything is all system engineering and all those things that I do. So you have to carry the burden of carry on the burden of understanding and empathy and sympathy. All of them are. Thank you so much, Dr. Reddy. The final word. You want to say anything? Let me ask you: are you planning to do anything in the role of a federal government? Or are you planning to go work in the policy level, change everything? What is
I'm gonna quote Dickie V, who's also a cancer research advocate. I'm gonna take a little bit of time out, right? So here's the thing. I encourage. It was hard. I'm not going to say that process was easy, but I encourage people to get involved in public service. I really do. I mean, I got more out of the process as a positive than a negative. And the ultimate truth is, if you really want to make a difference, don't make politics and public service a dirty word. That should be the ideal of public service. And so, so for those folks that are worried, yeah, it sucks sometimes. And, that's a scientific term, right? It is what it is. But the things that are worth the most in life are often the things that are where you struggle and you fail and you get knocked down, but you got to get back up. Life is about resiliency. There is nobody, very few people, I should never say nobody, where it's a straight line. And so the key to life is when you get knocked down, you get back up. Then you'll be successful. You'll get to where you want to go.
Excellent. Excellent. The miracles always lie right on the other side of what we're avoiding. So wonderful advice. What a pleasure, Dr. Reddy. So nice to meet you.
Truly educational, always talking with you, and you always never disappoint anything. You're always inspirational to me, Dr. Reddy. I'm glad that so one day we have to, that Susan now fell in Andhra chicken curry. So we have to tell her how to make dishes of that, So thank you all. Good night. And stay on the line, and then we'll talk a little bit minute. So good night, all of you.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.